Awesome. Thanks, Ramya. So for those of you who don't know, HIV is a human immunodeficiency virus, and it is a virus that attacks the body's immune system. If HIV is not treated, it can lead to AIDS or acquired immunodeficiency syndrome. Currently, right now, for HIV and AIDS, there is no cure, and once someone contracts it, they have it for life. HIV is transmitted through anal, vaginal sex, sharing needles, syringes, or other drug injection equipment. And it has existed in the United States since the mid to late 1970s and is one of the world's most serious public health challenges. From the first days of the AIDS epidemic, the history of HIV has been one of stigma and activism as well as science. The earliest people with AIDS and the health officials advising the public didn't know what the disease was or how it was transmitted. And this uncertainty and the speed that the disease spread at led to an epidemic of fear and discrimination against those with HIV and against groups perceived, correctly or not, to be more at risk. Some statistics before we can get into our questions. In 2018, gay, bisexual, and other men who have sex with men accounted for 69% of all new HIV diagnoses in the US. By race and ethnicity, Black African Americans are most affected by HIV, with them accounting for 42% of all new HIV diagnoses in 2018. And around the world, about 39 million people are living with HIV, and sub-Saharan Africa accounts for about 61% of all new HIV infections. Since the development of combination antiretroviral therapy, HIV/AIDS professionals have focused much of their efforts on expanding access to the medications in that treatment, since individuals with access to this treatment can live relatively normal lives. And recent modeling, given the COVID-19 epidemic, has estimated that a 6-month complete disruption in HIV treatment can lead to more than 500,000 additional deaths from AIDS-related illnesses. So that is why we are here today. We are going to be discussing some important topics related to these. And before we get started, Dr. Wamai and Dr. Dybul, again, thank you so much for being with us. We were wondering if you guys could give a brief introduction in the current work that you do and what you've done in the past to address this epidemic. Dr. Wamai, if you want to go first.
I can, and yeah, thank you very much. Yeah, Dr. Dybul, I can go first because I'm faculty at Northeastern, so let me do that. And so students, everyone, all of you here, colleagues, I think I have a couple of colleagues on, and some of my students in my class, and they know I've been talking about HIV quite a bit. My work on HIV and AIDS started a long time ago. I would say in 2001, actually in Baltimore, when I was a research fellow at Hopkins, when I did my first examination of HIV/AIDS in inner city Baltimore rather. And then years after that, completing my PhD in Helsinki, I then, during my postdoc at Harvard, started working more intensively and deliberatively on HIV and AIDS in the African region. So that's from 2006, and did quite a bit of work. That was an interesting time because 2006 was when initial studies from the African region, the 2 randomized trials on male circumcision came out. The first one in South Africa in 2005, and then the 2 ones in Kenya, one and Uganda in 2007. So I was involved in a lot of discussions about how male circumcision can be implemented to tackle HIV and AIDS in the continent, and I wrote quite a bit of research on that. And then also I've done some work on technical efficiency evaluation studies in several countries in the African region. And more recently moved on to working on non-communicable diseases and neglected tropical diseases, and then looking at the effect or comorbidity aspects of HIV, NCDs, and NTDs. So my most very recent work on HIV was a paper published in the special issue in the AIDS conference earlier in the summer, looking at modeling for HIV in Kenya to 2033 in context of NCDs like diabetes and hypertension. And early in the year, using the same data from the National Stepwise Survey for Kenya, we also published modeling for HIV and hypertension in South Africa and Kenya to 2028. So I've become much more interested in looking at HIV in context of these other diseases, NCDs, NTDs, particularly visceral leishmaniasis and comorbidity for VL, and HIV and AIDS, of which work I'm involved in northern Kenya as we speak. Yeah, so that's where I am with with my current work on HIV and AIDS. All right.
Thank you, Dr. Wamai. And Dr. Dybul, could you please tell us a little bit about your work in the past and any ongoing work you have?
I'm kind of afraid it's going to take, we're already 20 after and I have a hard stop. So my background is as a researcher, initially studied with Tony Fauci at NIH, my mentor and friend, then worked at PEPFAR and the Global Fund, now at Georgetown University.
Thank you for that, nice and brief. So we're gonna get right into the questions. And the first topic will be the worldwide view and response to AIDS. And anyone can go for this first question, but what are some of the social determinants of health that affect the prevalence of AIDS in different populations, and how do they compare between the US and developing countries? Anyone can go.
Yeah, Dr. Dybul, you want to dig into that?
If you'd like, or the students can as well. The epidemics are somewhat different. The largest epidemic, as you heard, is in Africa. That epidemic is driven principally by heterosexual contact, especially in younger people. Younger girls, 15, sometimes younger, to 20, and older men, 25 to 35, are the two highest risk groups. There are traditional key populations: men who have sex with men, injection drug users, which are actually growing in countries like Kenya, South Africa, and a few, Nigeria, Senegal. But it's heavily among young heterosexual transmission. The United States is a different epidemic. There are about 50 counties in the United States that accounts for 80% of new infections. It is driven almost entirely by Black men who have sex with women sometimes because they are dually discriminated against, HIV positive and Black, have no access to healthcare, are afraid of healthcare, high stigmatization, discrimination. That is the case in Africa. Young women are at high risk because basically sexual violence, abuse, and gender inequality. Gender inequality drives the epidemic in sub-Saharan Africa in the same way that stigma and discrimination drives the epidemic in the United States.
Yeah, I could add that particularly when thinking about the, of course, sub-Saharan Africa has a generalized epidemic, like Dr. Dybul, you mentioned, it's primarily heterosexual. There are many studies done earlier on, funded by the World Bank and others, called, a sort of modes of transmission analysis. And so when you think about social determinants of health, you are specifically looking at what? Education levels, income levels, households.
That is a little bit different, right? So it
Yeah.
is not the poorest of the poor in Africa in general that are infected with HIV. There are very low rates in many rural settings. It's actually people who have a little bit of money. Teachers, healthcare professionals, nurses in particular, were being wiped out in much of the continent early in the epidemic. Truck drivers. So it's people have a little bit of money. There are serodiscordant. There are multiple concurrent partnerships, which is a more common cultural phenomenon. Minors, factory workers. So it's actually it's not as driven by. It's definitely not poorest of the poor by any stretch of the imagination. But people who don't have access to healthcare or educational facilities. But really, the vast majority of people know about HIV now in sub-Saharan Africa. I also, to be honest, I have a problem with the term social determinant. It's a nice euphemistic academic term for what is just straight out stigma, discrimination, racism. And we should call it what it is. It's not a social determinant. It's fundamentally racism, discrimination, and stigma, and it drives people. It does reduce their ability to have resources, but it also fundamentally keeps them from seeking healthcare even when they have resources, or even when resources are available. They're hidden from the world, and it's just appalling. Although now it's shifting. When you talk to the at-risk groups in Africa, they just don't think about HIV anymore. They have bigger issues. They think about jobs, access to the internet, education, water, food. In the work we do, it's on the top 15, even at the people most at risk. They don't view themselves at risk because there's not as many people dying around them, but they just don't have access and don't care about HIV in the same way. But it really is, it's just flat out discrimination, racism, and sexism, homophobia. And I think we should call it that and not use social determinants.
Yeah, we certainly, the scope of the epidemic is quite broad. I'm from Kenya, and I've worked there many years. As you know, and we've looked at some of the data, some of the students here in class looking at specific countries and the distribution of HIV across sub-Saharan Africa. It's also driven by other cultural factors. If you look at Kenya, for instance, the prevalence rate in certain populations with low levels of male circumcision are very high compared to regions where I come from. That is clearly a cultural element. And now I know interventions have been targeted towards improving, for instance, circumcision coverage for those populations in those regions. But you're absolutely, looking at the US context, the drivers here are not quite the same. But certainly using a term like social determinants of health, which is a broad-based framework, can help us tease out some aspects of those. And probably, Dr. Dybul, we might include aspects of racism. The true fundamental cause of those aspects are much beyond just the regular or standard explanation of the SDH. Yeah.
Thank you for those very detailed answers. We really appreciate the insight. And Dr. Dybul, when you're referring to that, they just don't care about HIV anymore because they have other things to worry about. Then how do you address that? Is it because of misinformation, or is it the health literacy of the region that is affected? How do you think?
I think it's because we have too many health professionals and doctors leading the response. We used to actually rely on communities at the beginning and listen to them. We don't anymore. They're completely separated from the response because it's become totally medicalized. Like an issue on male circumcision, which is often a religious, cultural issue. You're not going to solve that problem by opening another male circumcision clinic, which is what we do. You have to actually go in to listen, talk to the religious leaders, talk to the local leaders, talk to the men about what they will and where they might actually do programming, what their concerns are. When people have done that, we get very different answers than the healthcare professionals thought were the solution. And so what we have to do is go into communities and do what was done at the beginning. Let the communities lead. Have them explain why. So when we engage with young people and talk about what their issues are, and they'll tell us, I'm never going to that clinic. I will never in my life go to that clinic or any other clinic. I'm treated badly. It's a bunch of old people. I'm not going. But if you ask them where they would be tested or what kind of programs they want to engage in, then you start designing programs around them. We've done that in a variety of places. In some places, water is the principal thing. And then the HIV program links with the Ministry of Water and Sanitation in Eswatini, for example. About 700 people have gotten access to water through just talking to young people because they cared about water. Job creation programs, entrepreneurship programs. We keep thinking if we build clinics closer to people, they'll just go to them and that they'll access health services. It's absolutely crazy. Same with boda riders in Kenya, where we're very active in Homa Bay. They didn't care about HIV, even though they're very highly at risk. They care about road safety. They cared about police harassment. And so we worked with them and the governor's office and actually gave them access to the governor's office. It was very interesting. The governor's like, why should I listen to you? And they said, we have 40,000 riders in your county, and you should care. And the governor's ears perked up immediately. He brought in the department, he put in his own money, brought in the Department of Transportation, fixed the roads they were most concerned about. There was a hotline to someone in the governor's office anytime one of their riders was harassed that they could engage. And once you start engaging in what they care about, they learn to trust you, and they start hearing what the data are, how at risk they are, which they had no idea, how at risk their riders are, and the sex abuse that occurs within the riders themselves. And they have a highly structured community, not just in Homo Bay, but actually a national structure. It's almost like a parallel government. And they engage, and now we're engaged with them and sit down with them, with the head of police, the head of the health department, the head of road safety, and have conversations that cut across these issues. So it's back to the beginning. Go into communities, listen to them, respond to them, and don't just do top-down. It's the same with vaccines, and we're going to go through this with COVID. The data are overwhelming. Just telling people it's good for them is not going to lead to anyone accessing services. And so if you don't meet people where they are and engage with them, especially in the context of people not dying around them, and the availability of treatment, which we know leads to disinhibition, the data are overwhelming, does in the United States. If you don't engage people in a different way, we're going to have really an explosion of HIV because of the demographics and the increase of young people in sub-Saharan Africa. And we're not going to contain the epidemic in the United States in the pockets where we still have high transmission.
Absolutely. Thank you. And kind of on that same tone, Dr. Wamai, maybe you can speak to this, but how do developing countries' access to treatment differ from developed ones? And how do you predict these trends will be in the ongoing access to treatment to the COVID-19 vaccine?
Well, I think actually the question of access is a broad question, and I think access here with treatment for HIV will be measured not just having access to it, as we know that we have these targets, the 1990 targets for awareness, for access to antiretroviral treatment, 90%, and then 90% for viral load suppression. So probably, I don't recall off the top of my head what those numbers are, but they're not very, very bad. And they're not that different. Probably for sub-Saharan Africa, they may be better than the United States, probably in terms of those statistics of particularly access to treatment and probably also viral load suppression. I know these contexts vary quite a lot from country to country, from population to population, and so on and so forth. Some countries have very high levels of these coverage rates, like Eswatini. The other countries like Rwanda have very high access, so the coverage. And then viral load is assessed according to the levels in which these countries have been able to reach across the board. And some countries are doing better than others. So part of maintaining good and high levels of viral load suppression has to do with access, but retention to access. I think you did mention in your opening remarks that COVID-19 in some modeling might have increased mortality due to HIV with 6 months of no access to treatment. Now, clearly, obviously, there will be no situation in which you have large numbers of people having no access to antiretroviral drugs for 6 months. I think that scenario is unlikely to happen. And so, obviously, maintaining a high viral load suppression will have those multiple effects of reducing new infections, but also increasing, health outcomes for populations with treatment, and certainly become a game changer in terms of consistently reducing new cases of HIV. COVID-19 has a whole other set of challenges, but it also has, I think, opportunities that we can learn from interventions for HIV, which we can speak to a little bit later. I should mention too that all these type of interventions, like the one Dr. Dybul was describing for Nyanza or Western Kenya, if you take one region in Western Kenya, you take another region like my region is Central Kenya. Dr. Dybul, you'll be familiar with that. The factors behind why new infections obviously have been coming down in most places, including in Kenya. But as I heard today, I talked to a colleague in the Ministry of Health in Nairobi. One of the challenges, given today's World AIDS Day, and you have these discussions that are made and happen in national media, in the evening news, some reports, are indicated. The thing is that there is not complacency as such, but even in these national programs, the lead agencies that used to lead the HIV interventions, like NASCOP in Kenya, the National AIDS Control Council, and other institutions, and throughout the Ministry of Health, and throughout this multi-pronged intervention from the Office of the President all the way down, the emphasis and the stress that our institutions used to have on HIV and AIDS, including media discussions, including billboards on the streets, in rural centers, health facilities, and so on and so forth. There has been a decrease in spending for these interventions, or just in emphasis and ensuring that there is a maintenance in communication and messaging for behavior, for access, and so on and so forth. I think that that is probably likely the case in many contexts in sub-Saharan African region. And once there is a decline in this messaging, I mean, clearly, early on in the epidemic in the 1990s, in 2000, you had large intervention from community-based organizations, just like you were describing, including local leaders being involved and so on and so forth. We are now looking at a generation after, almost a full generation, another 10 decades or 10 years or 20 years after those initial very high level broad-based interventions. And it just seems that there has been a laxity in these type of broad-based interventions across the board. And that, I think, creates another set of challenges for almost a new phase, post-pandemic phase, in how we might respond to HIV and AIDS.
Thank you so much for that response, Dr. Wamai. Dr. Dybul, do you have anything to add to that previous question?
I would just point out two things. There's an excellent answer. I agree with everything you said. There are only two countries in the world that have achieved 95, 95, 95. Eswatini and Switzerland. No one else is actually within percentage points of them. So, however, and even in the United States, the difficulty we're having is who's in that last 5%. And what we find is the people most at risk are not accessing services. It includes people who have HIV, like young men who are not accessing services, and young women who are very highly at risk who are not accessing services. And so you can have exploding epidemics. So in Eswatini, in a trial of women who were seeking family planning, the HIV incidence rate was 3.5 to 4%. These are women who are seeking health services and have an incidence rate of 3 to 4% in the context of 95, 95, 95. Same in KwaZulu-Natal, which is over 90%, 90%, 90%. They have had a steady incidence in young women that the Qureshi Karim and Slim Karim have documented for 15 years, the same rate, despite increases in antiretroviral therapy, of 6 to 8%. This is incidence, not prevalence. Those are new infections every year, 6%, 6 to 8%. And what that tells us is the theory of just getting treatment coverage out would end the epidemic is nonsense. There are now randomized controlled trials, multiple randomized controlled trials that tell us it's nonsense, yet we keep having international organizations pushing that agenda, despite randomized controlled trials, the gold standard saying this is not having a population impact. And so what it tells us is we are still missing the most vulnerable because we're not listening to them. We're not responding to their needs. We're medicalizing, responding to our needs as doctors and as healthcare leaders. And we're not listening to the people who are most at risk and reaching them. And unless we do that, this epidemic could get totally out of control. You hear discussions, and I heard it again today, that we're reaching epidemic control. That is garbage. I cannot tell you what kind of garbage that is. It's a ridiculous epidemiological definition that makes absolutely no sense. More deaths compared to new infections. Yes, that counts for acute infections like Ebola, but has nothing to do with the chronic infection. We don't talk about that diabetes or hypertension that way. We are so medicalizing and so over. So I think the important point is access to treatment is absolutely important, and everyone should have access to it. And if everyone took it who is HIV positive, the epidemic actually would come under control fairly quickly. But the most vulnerable are not. And so just pushing more treatment out is not going to answer or solve this epidemic.
Yeah.
Thank you so much.
Yeah.
Yeah. Sorry about that. Yeah, no, I just want to add that, I just realized that, I've never really heard about these concerns, and the notion of exceptionalism, through my health education. And so it was really enlightening to, hear you put this in perspective.
Mhm. Yeah, I was just going to add a point because Dr. Dybul has talked about Eswatini particularly. I mean, absolutely, I totally agree with that. There is a study from Eswatini published earlier this year that even if you had 100% universal coverage for antiretroviral drugs, you would introduce incidence. By 2050, it would only be 0.46 per 100 person years. So the reduction in new infections would not be that significant even with a 100% scale up of antiretroviral drugs. So quite clearly, there is a need for other interventions. And of course, within HIV, we speak about combination interventions, which I think is one of the lessons that we can draw from HIV into COVID-19, where we hear it's not just one size fits all, it's not just one thing that fits everywhere. You have to have a combination of approaches.
Thank you. And going off of that kind of, so because we're a little bit pressed for time, our last section kind of focuses on the US response to AIDS. And Dr. Dybul, we were wondering if you could take this one. So what role does racism play in the US response to the AIDS epidemic? And how have you seen this pattern repeated during the ongoing COVID-19 response?
Yeah, so it's a great question. As I mentioned before, it is the principal, racism combined with homophobia are the principal drivers of the epidemic in the United States. And you can tell by looking at the counties where we still have high levels. And, as Dr. Wamai said, cultural issues are very much at play here. So in the African-American community, especially in the South, being gay is not acceptable. And so there's that double stigma and discrimination against gay Black men, especially in the counties where we see so much HIV. And because of that, they often, that's why we use the term men who have sex with men, which is a terrible phrase. But the reason we have to use it is because, and this happens all over Africa, we actually did a study with people at the University of Maryland to show this. If you are stigmatized for being gay, you will have sex with women. It's actually not bisexualism. That is definitely out there too, but these are gay men who basically have to have sex with women. And so they transmit the virus to women. And so that group accounts for much more infection in young women than bisexuality or heterosexuals. So it's a spillover effect that's pretty dramatic, but it's racism, but it's also serious cultural issues within the African-American community around being gay. And that's what's driving the epidemic there. I mean, there are projections of rates, it's probably a little bit too high, but in certain Black African-American gay communities, the rates are as high as 50%, which is what they were at the beginning of the epidemic in the United States. That's probably a little high, but it's anywhere within 10% of that is appalling. And so we need to tackle some of these issues head on. or people just won't ever access the services. It's just fundamental to what's driving the epidemic in the United States.
And how was the U.S. response, or I guess what was the United States' role in the larger global response? I guess speaking more to your work as the executive director of the Global Fund, how did you see the U.S. handling the epidemic in relation to other countries?
I might be able to answer that better from having helped start PEPFAR and having run PEPFAR, since PEPFAR is much larger. It's three times the size of the Global Fund resources for HIV, launched by President Bush with strong bipartisan support for 15 years now, 18 years now almost. It's just extraordinary. It's one of the most remarkable things that's ever happened in this country. And really, until that leadership from the United States, and to some extent a Republican had to do it, and President Bush believed deeply in it, without that, we would be nowhere. Really, PEPFAR changed everything. And I still go to meetings with heads of state in Africa, even ones who weren't around then, and they just go off script and start talking about PEPFAR and how radically it changed the lives of their people. Not because we were, and this is a difference which I think this administration will get back to, we were supporting countries to scale up their programs and own their programs so that they could respond. Not telling them what to do, not coming in and saying, this is what you have to do. And there's been too much of that. That paternalism is very strong in development, not just in health. And there's been a slide back of that in the United States, the way it engages in African countries. And I know this administration will reverse that. But that was really that's what changed everything. Largest international health initiative in history for a single disease. It's astounding how few people know about it. It really, and I'm saying, my African friends will say this too, it fundamentally changed the trajectory of the epidemic. The Global Fund was critically important, but the resources were less than what was being provided through PEPFAR, and still is. The US response, I think, the reason it's important, there are two reasons I think it's very important compared to Africa. One is understanding that stigma and discrimination is not just, people tend to talk about it like it's just happening in Africa with young women. It's what's driving our epidemic. It's what's driven our epidemic since the beginning. It's what drives every epidemic, and it drives, COVID. Socioeconomic, cultural issues are driving COVID too. The African American community it's like the double whammy of being gay and Black in the South, although it's not just the South, it's in other counties as well. Black people, poor people are disproportionately affected for multiple reasons. One, they have to go to work. They're frontline workers. They don't have the luxury of doing Zoom like we do. They have to go to work, and so they're far more exposed. They have far higher rates of comorbid conditions, diabetes, hypertension, because they have poor health and health care. And then the last piece is they have poor access to health care because they're poor and discriminated against. So all of these things add up, which is not too dissimilar from what we see in HIV. The last piece of it could be genetic. Bradykinins and other diseases, other key factors that we now know or think play a key role in progression of disease are higher in African Americans than they are in other populations in the United States. That could be genetics. It could be because bradykinins cause leaking of fluids, basically. And so if you have higher levels of bradykinins, you're going to leak more, which is what causes the disease. It could be genetic. It could be because of all those other factors. It could be because they have poor health and diabetes and hypertension and everything else, and poor access to healthcare. So, these things are confluent things, and that again gets back to, if you think a medical solution is going to solve these problems, you're not focusing on a person, and that's what we need to do. Focus on a person. What are their needs, wants, desires? What is their potential to grow? How do we engage them, meet them where they are? And if you do that, and again, I go back to the early days of the epidemic, we didn't save anyone's life because everyone would die from HIV. But the communities came together to serve, to support. This happened all over Africa, still is happening, fortunately, despite the lack of funding. We've lost that. And I think that's a really important lesson from the early days of HIV that is relevant to today, that without that community engagement, without that community leadership, without engaging with human beings, rather than trying to just push pills, we are not going to solve this epidemic. And it's going to be the same with COVID. It's the same with the vaccine. 50 to 60% of people are saying they're not going to take the vaccine. Just by saying we're going to distribute vaccines does not mean everyone's going to take the vaccine. And we know this from annual flu vaccines and lots of other things. The anti-vaxxers are revving up. If you don't engage human beings, you're not going to solve these problems. And I think we've learned a lot from HIV that can contribute to the response to COVID on that.
Thank you so much for that response. Dr. Wamai, do you have anything to add to those previous couple questions?
Well, I think I'll just reflect briefly on today, World AIDS Day, the theme is resiliency and impact or something like that. And, I totally agree with what Dr. Dybul has said regarding what's driving the epidemic here, what needs to be done here and back in the continent in Africa, as well as the fact that you have these concentrated epidemics. It is, if you looked at the statistics for the CDC in this country, you still see that there is young people driving the epidemic. So people in their second generation or third generation of life are driving the epidemic. So increasing infection in young people, I think that speaks to not complacency as such. I spoke about probably I could use that term complacency on behalf of my government in Kenya or interventions. It's not that they're not receiving funding. It's not that they haven't allocated funding from their own country budgets. That is required. But how is the response being carried out? Here, I speak with my students and ask them. So most students, most of your age now, don't know much about HIV and AIDS, except if you're engaged in it. So it used to be a disease of the generation that is, ahead of you. It is not today. So you don't have much contact of information or awareness or reminders about this pandemic. And yet, as we speak, it has a much higher case fatality rate compared to COVID-19 by a lot. I mean, given that nearly half of persons who have ever been infected with HIV have died, so quite a huge number. But the thing is that awareness, I think, is declining and has, produced a generation of your generation, particularly, who don't have those memories, don't have those images, don't have those reminders and those awareness, and that is happening as well back in the continent. In the 90s, in the 2000s, you would see a lot of information in every setting, in university campuses, in small health centers, in community shops, in rural areas. But you don't see that today. So I think that remains a challenge. And so it seems that there would be, like Dr. Dybul mentioned, we are nowhere near to controlling the global pandemic. And I think COVID-19 has obviously cast a shadow or setback to interventions everywhere. I don't think necessarily that funding may decline. PEPFAR has been this huge global program, like Dr. Liu mentioned, that has supported most of the treatment programs in the continent in Africa. Most of the male circumcision interventions have been supported by PEPFAR. But even other interventions, for example, for abstinence interventions, those were not that successful, or even expanding use for condoms and so on and so forth were not that greatly successful. But we have to continue. So it has to be that this kind of conversation you're having, you have to have it more frequently, and I think there's need for increased education and information among your generation here, both and also in the continent, because ultimately it will remain this behavioral disease that is cutting across from one generation to the other generation.
Thank you so much. And those are all of the questions that we had for you both this evening. And thank you again for spending your time with us and informing us on such an important topic. I know, Dr. Dybul, you said that you have another meeting to get to at 7, I believe.
Yes, another World AIDS Day thing. But I also want to thank you all for being interested. You know, as Dr. Wamai keeps saying, you know, the solutions are going to come from your generation, and there isn't as much interest in activism as there once was among young people. And that's part of the reason we see so many infections in young people. So, you know, your engagement is hugely important. So thank you for taking time and focusing on this issue. Without it, we can't get anywhere. So thank you, and thank you for including me. I'm sorry I have to go to another World AIDS Day event.
No worries. Thank you so much for your time.
And I'd just like to mention that Dr. Dybul will also be at our conference in March. This isn't the last that we'll see of him, but yeah.
And Dr. Wamai, if you have a little bit more time, we have some questions in the chat.
Sure.
If you'd like to answer them. Okay, so Lily said, I was curious to know if there was a particular past response to an epidemic that you found to be exemplary, and if so, which parts of that response do you hope to see repeated in future global or national responses?
And this specifically is pandemic responses, right? Yeah. Well, we would have to say that in the history of global health, I mean, the greatest would have been and still remains the response to the eradication of smallpox, period. We don't have anything close to that. How did you get there? We got there through vaccines. Now, and we've talked about vaccines, and like Dr. Dybul has mentioned, as we have been hearing too with Dr. Fauci here saying, yeah, we will have a vaccine for COVID. It's going to be probably as effective. I mean, 95%, as we've heard, could be close to what the smallpox vaccine reached in terms of efficacy. The question is, are people going to take it? Now, I think we can revisit the lessons from smallpox. How did we do it? How did we get, so many millions of people, in fact, take up and accept the smallpox vaccine? I don't know. I can see we have Professor Brooke Baker here. He's a little bit older. My father is the one who immunized me with smallpox vaccine in our home that he had built for us. But I can't remember what was those scaled up interventions that actually reached those large millions of people to actually take up the vaccine. Beyond that, I would use examples related to, let's say, distribution of drugs for treating neglected tropical diseases, using what's called the mass drug administration, in which these drugs are administered across whole populations without necessarily having to test them, because the drugs are, one, effective, two, they don't have toxicity that can have negative impact of whether it's the children or pregnant women or adults who might be at risk of these neglected tropical diseases like schistosomiasis. So those would be large interventions, for targeting specific diseases. And I think we could use another example would be the near eradication of guinea worm disease, drunkenculiasis. Without medication, without diagnosis, we have only a few handful of cases remaining in a few spots in just a couple of countries in the Central African region and Horn of Africa region, and that a disease that used to affect millions of people is almost eradicated without any diagnosis and without any treatment. I think those are remarkable examples of great global pandemic responses. But I mentioned Professor Brooke Baker, so I would really like to hear his perspective about, vaccines and smallpox and COVID. So good to see you.
Well, good to see you. And I remember being at your Fireside chat last year. I think, no, 2 years ago it was, wasn't it?
Yes.
Yeah, two years ago. And
in person.
Yeah, and in person, yeah, we weren't distanced. So I'm sorry to be a little late to this, and certainly appreciate that everyone turned out. Though I still notice that we have a predominant number of women students who are, interested in this. Richard, we have to do a better job of getting some more male students interested in global health justice as well. So, I mean, I think that the COVID situation is pretty significant. I just want to mention, I missed the first 20 minutes, so I don't know what was raised. And, I think I had a little bit of disagreement with some of the things that were said about medicalization and access to treatment and vaccines. I think many things can be true at the same time. We can both need more vaccines and treatment and also need to do comprehensive prevention and reach populations that are stigmatized and criminalized. But I think the COVID response, we have a really new kind of problem. And I mentioned this in a class I came to work to present to Richard's class earlier in the semester, is that we have an undersupply of necessary products because we let drug companies decide who gets to manufacture. And if they don't want to give technology transfer to other companies to make more vaccines or more medicines, then the supply is limited. And when the supply is limited, then rich countries and rich buyers run to the front of the line and scoop up available resources. When I spoke in Richard's class now 6 weeks or so ago, I think it gave one figure about how much has been advance purchased.
Yeah.
But the most recent figures from Duke, are that over 9 million doses of vaccine candidates have been pre-purchased, mainly by rich countries, by the US, UK, Europe, Japan, Australia. And the idea that rich countries, partially because of shortage and partially because of economic and political power, and because of the market-based system we have, can run to the front of the line so that everyone in the U.S. will get treatment perhaps before anyone in Lesotho will. It's just an outrage, right? It's just a symptom of the global inequality that we have, and the consequences of organizing ourselves in a way that really uses a profit-based system to deliver essential health products that are necessary for global survival in the current context. So I just wanted to add a word about how important the HIV response continues to be, and I really appreciate the emphasis on young people becoming more aware of it. But of course, it's true for all health problems. I mean, your generation is going to be the people who decide whether we're going to have the same terrible response to a global health pandemic that we now have 20 years from now when the next one rolls around, because the next one is going to roll around. Yeah. Richard is old enough, even though he says he is younger than me, to remember we had SARS, we had MERS, we had 2 coronavirus pandemics that were on the verge of becoming potentially as dangerous as this one. That's we're not quite as infectious and we're ultimately contained. But the writing is on the wall. This will happen again, and if you all are helping to make the world prepared for it, we're gonna be in sad shape once again.
Yeah.
Thank you so much for your input, Professor Baker. So there were some more questions in the chat, and also, Dr. Baker, feel free to join in and add your input. It's very appreciated. So Andrew asked, given that clinical trials take so long for new treatments and medications, do you think do you think this is also a serious problem for access / distribution of care?
I don't know. I'll leave that question to Brooke.
Well, one of the things we've been focusing on is when you have a system of exclusive rights, so each company is basically intent on bringing its own product to market, and basically trying to find studies that will prove its product work. A lot of the studies are underpowered. So 80% of the studies, the clinical trials that are currently organized for the COVID response, are underpowered to deliver clinically meaningful information on the safety and efficacy of the products. 80%.
Wow.
Okay.
Wow.
And instead of having comparative trials, big high-powered studies where you could compare vaccines, where the same protocol was used, where the same endpoints are used, when the products are actually compared against each other, and to really discover some might be better with some populations than others. Some may protect older people better than others. Some might be, certainly there will be ones that are more appropriate for use in resource poor settings. We allow the industry to organize according to commercial prerogatives, not public health prerogatives. Public health prerogatives is we would have comparative studies that are highly powered, and we would get much more and better information, and we wouldn't have all this wasted time and effort. So, partially respond to the question about clinical trials for me is we can no longer tolerate a system in which the control of clinical trials is largely left in the hand of companies whose main perspective is commercial interest. It just doesn't give us the best results.
A follow-up question to that, how do you see the role of like health literacy being spread by, I guess, the companies that are conducting the clinical trials and governments? Like, what is the role of health literacy when, I guess, like arming a population against a pandemic like the one that's happening right now? Kind of talking about like anti-vaxxers, like I feel like, especially like with the clinical trials and stuff, like so many anti-vaxxers are saying like, don't take the vaccine, stuff like that. So that's just that was my own personal like follow-up to like what you just said.
Well, I'll answer quickly, and then Richard may have something as well. Again, if you leave the health promotion to companies, they're going to promote. They're going to select information. They're going to promote their products. They're going to, mainly be pursuing commercial interest, right? And the company is not going to say, my medicine is pretty good, but that other company's is actually much better for you. You should take it instead. That's not going to happen, right? So if you want people to have true health literacy, you have to give them accurate information. And unfortunately, I don't think that accurate information comes from the companies to the greatest extent. And, I don't think TV ads on ABC News, which almost no one watches except people in my generation, are going to convince the anti-vaxxers to start taking COVID vaccines, right? It's just not going to happen. So I think one of the things I did agree strongly with what Richard and Mark Dybul had to say is that you need to get out in communities. We need to actually be talking with people. We need, culturally competent interlocutors to be out in the community, finding out what people's hesitancies are, trying to reassure information with, people with accurate information, but also personal contact, and what will make it easier for people to get vaccines. Like some of these vaccines are not going to be easy to get. But Pfizer is, has to be stored at 70 degrees below centigrade, right? Yeah, that's pretty cold. That's not going to work in Montana very well. Well, maybe in the dead of winter they'll have a little. I'm picking on Montana because I think it's pretty cold, but I don't know.
Yeah, those are complex issues. I think with health literacy, I was just going to say, ask the students here, I mean, you who are listening, think about it. Where do you get your information from about anything, about COVID, about the pandemic? Is it from what sources? And then the thing is, are those sources reliable? Have they shown consistency in communicating correct, consistent messaging across the board? I mean, I think probably we could all agree that Dr. Fauci has been the lead in the pandemic response. But I mean, him as NIH, and then you have the White House task force, that's a whole other entity, and then you have CDC, and then you have the media, sort of a big cable media, and then you have Twitter, and then you have all other type of sources. So and we know that in some studies that have shown that President Trump has been the lead person propagating false misinformation and falsehood across the English media as himself. So, and certainly there are those who listen to him. So can you change those dynamics from the top down? Certainly by changing the person who sits there, by relying on science. There has been studies, surveys done across the globe about, which populations have, what levels of trust in science, or what levels of trust in vaccines, and so on and so forth. I think quite clearly this marketplace of information is quite complex, and certainly, just as any market, when you're going to pick up tomatoes or apples, you find a whole variety of those apples, and then it all becomes discrete choice. Which one do you prefer? Do you prefer an apple that looks shiny or whatever? And then you pick that. So is this marketplace of information that is complex, and some people simply do not have the capacities to navigate those, because after all, we all have degrees of inclination about who we listen to, the level of trust that we have in our public institutions and speakers, as well as the trust in science. I mean, WHO did say that you have these anti-science as a great global health threat, and that hasn't changed. With COVID-19, I think it has just become worse in this case. So it's a huge challenge, yeah. I don't know if, I'll just speak very briefly, Brooke, about a question that I see here from Navina Kumar. This is back into HIV and AIDS. And she was asking a question about whether we could speak of the efficacy and potential for pre-exposure prophylaxis in high-risk populations. Well, outside the United States, in the United States, that's a whole other different thing. But with PrEP has been, I think, has been approved, and Brooke, you know this better, in 2012 in the United States, and has been included as a standard recommendation within the WHO system since 2015. However, availability is actually dismally low. In fact, in 2018, only an estimated 200,000 people were receiving PrEP, and in the US, 75% of those global numbers receiving PrEP was in the US. However, even here in this country, there is a high level of awareness, and in fact, awareness in terms of awareness that PrEP is available and you can take it, but the willingness in one study was just 44%. And even in some places extremely low at 20%. So that could raise issues about, and I know globally, in fact, my country, Kenya, I think was the second country outside the United States to accept and include PrEP availability in as policy, as national policy. But so there will be a question of access. Certainly, if you have high levels of awareness and the willingness is lower at 44% in the US in at least one study published recently. So you have issues. You have issues of people believing one thing works, but then accepting another thing. And then the third scale is then the access question. People have access to it, and access is then determined by many other factors, including whether some people have health insurance, or they can afford it, or it is available, or other questions like those. So I think the bottom line to your question, Avina, would be to say that PrEP as antiretroviral drugs, as male circumcision for HIV, individually, it is not a game changer, but in combination, yeah, all of these can become a game changer. Yeah.
I would just add on PrEP is that there's been actually abysmal work on educating, but let's take young women in sub-Saharan Africa, right? What access do they have to health education? What access do they have to real understanding of the sexual mechanisms of transmission? How convenient is the method for them? I mean, one of the positive things that's happened is just in this last week, there's been, approval of a new vaginal ring that would help prevent HIV transmission. So a form of PrEP. There's just been a new long-lasting injectable PrEP that's not based on tenofovir and terbinafine, but a different medicine. Yeah. And they even have a kind of pellet that can be inserted under the skin, like some long-term contraceptives are. But the question is, are you really engaging with the thing about our discussion earlier is like, there's a new generation of people becoming sexually active every year, right? I mean, it's like, every second there's someone newly, becoming sexually active or interested. And are we reaching people at the right age? Or are we arming people with the information, even about the choices they might face? And I think we're not. I mean, I think that if all of you were to reflect on the sex education that you got in high school, or the sexuality education or the reproductive health education or, any of it. It's just not there, right? And so we aren't really, capacitating people to make wise decisions, and let alone providing them with the kind of options that would work best for them. Taking a pill every day for PrEP is not particularly easy to remember.
That's right.
I mean, it's not easy taking pills every day. So maybe long-lasting, versions will be much more effective. They found it early when they tried to use microbicides that women weren't particularly comfortable, inserting a foam or something into their vaginas before sex as a way of HIV prevention. It just wasn't something that women were comfortable doing necessarily. They worried about having pills because their partner might find out. And people were concerned that would be either an accusation against their partner or an admission of extra, relational sex by the woman. And so there's all these things that the lived experience of people that needs to be taken into account.
Yeah. Yeah, I think if we could conclude with that, I'll have to log off shortly. But just to reemphasize the point that Brooke, you mentioned, that I think young people, especially your age and even the younger generation behind you, are missed opportunities, probably. I mean, if we don't educate and inform people of your generation, then we're missing a huge opportunity, because you have an increased population coming into sexually active age. Now, sub-Saharan Africa average age is just 18 years. I mean, that's critical. That means that you have a very large young adolescent population. If 18 years is the average age, 18 years will be a person who was born early in the 2000s as the treatment started to ramp up on the continent. And then the decade after that, we have had, less and less interventions or information, the messaging question that we were talking about earlier on. So you have a young generation that is growing, and no wonder we see that they are the more at risk population, particularly girls, as Mark Dybul was speaking about earlier on. So there is this whole probably generation that is missed, and it might be a bit of time to begin to think about, oh, hold on, these infections are where they are, these new incident cases, and then we need to ramp up all over again what we did earlier on in the pandemic. Brooke, please.
I just want to say it's great to see you all, and to see you again, and always a pleasure to see Richard, because he and I have been working together here at Northeastern for over a decade now. I don't even know how long it is, Richard, but maybe it's 12 years. I don't know. How long have you been here?
It is 12 years, yes.
Yeah, okay. Yeah. My memory's not completely gone yet. So.
Yeah, no, you're fine. So thank you. Good to see you, Brooke, and good to see everybody. Yeah, all the best.
Thank you, Dr. Wamai.
All right, bye-bye.
Okay, so I think those are all of our questions. And thank you so much, Professor Baker, for stepping in. And
sure.
As well. And we will be putting the recording of this on our website and our social media. So if you know anyone who couldn't attend but wants to watch it, feel free to send them that link once it's uploaded. And thank you so much again to everyone who attended and stuck around until the end.
Thanks, guys.
Bye, everyone.